I'm Henry Cutler. I'm the Director of the Centre for the Health Economy at Macquarie University. Today I'm going to be talking about some work that is being funded by the National Mental Health Commission through a grant, and we were approached by them last year to consider how you would invest better into the mental health care system and how you could embed more value into funding mental health care services. We've been busily going off and looking at the literature. We've written a consultation paper, and that consultation paper was released yesterday. This presentation is really a broad overview of that consultation paper, and so you'll see some frameworks that you may be interested in. You'll probably have lots of questions. The purpose of this presentation really is to stimulate that discussion for the panel, but if you want more information on what we're proposing, please go to our website. The consultation paper will be there. And I might also talk to Catherine about emailing that consultation paper out to participants today. Okay, so let me just work this one out. Okay, it's just the acknowledgement to the National Mental Health Commission. All our views are expressed are those of myself and my co-authors. Okay, so we know the mental health care system has obviously been going through some considered thought. We had the Productivity Commission in 2020 finalise its inquiry into the mental health care system, and the Royal Commission, the Victorian Royal Commission into mental health care as well. In 2022, the National Mental Health and Suicide Prevention Agreement laid out effectively a vision for reform. And I'm sure some of this has been discussed earlier on today, and it will be discussed later on this afternoon and into tomorrow. But really, it's about unifying the mental health care system, reducing fragmentation within care pathways, delivering a comprehensive, coordinated, consumer-focused and compassionate system. And we've heard obviously a lot over the last few years around making sure services revolve around the individual, but also equitable access to the appropriate level of mental health care needed. And I'm sure you're all familiar with the concept of the missing middle, which was really coined by the Productivity Commission in its 2020 inquiry report, which suggested that there are a whole bunch of people out there who are effectively missing the services that they require, and there needs to be greater alignment of resources within the mental health care system towards need. So pushing some of those services away from those who may not need them when other services would better meet their needs, and reallocating some of those services to those in the missing middle who are severe enough to receive and require those services, but not severe enough to be within a hospital and receive inpatient hospital services. The Productivity Commission also recognised several deficiencies within the mental health care system, and if you've read the whole 1,200 pages of that report, you would understand that they basically covered off every part of the mental health care system. But to condense that into 4 key points, they really suggested that the roles and responsibilities were unclear across federation structures. And we've heard this 1,000 times about the incapacity of individuals to seamlessly move from federally funded to state-funded services. We also heard from the Productivity Commission that mental health care data is underutilised and fit-for-purpose data isn't being collected. They had a great chart in there around what data is available, and it is there is not that much data for the purposes of their reform, so they have also recommended increased data access and infrastructure. They suggested there was little measuring and monitoring of health outcomes and little accountability. And finally, programs are not being measured for their cost effectiveness before being scaled up, or there was little translation of research into practice. And a lot of that has been echoed throughout the sector for quite some time. So our research purpose was really to take a step forward from where the Productivity Commission finished and look at how we could potentially propose a framework for embedding value into Australia's mental health care funding and investment environment. Now, they're two separate concepts. So when we talk about funding, we're talking about how money is allocated to services, in particular how our incentives are introduced into the healthcare system to improve health outcomes and to foster integrated care across multiple provider types. And then when we're talking about investment, it's really about how decisions are made to actually start investing or continuing to invest or even disinvesting from the sector where services may be receiving funding, but they are not effective in delivering the outcomes, or that funding could be used elsewhere and produce a greater amount of health outcome. So the purpose is really for us to develop this framework as a long-term proposition that we can build on, looking at some of the reforms in the National Mental Health and Suicide Prevention Agreement. We believe that they can also be extended, particularly into funding and financing. Looking at the reforms outlined with the addendum to the National Health Reform Agreement, so that's currently being reviewed at the moment. Within one of 6 key areas of reform within that agreement, one of those is paying for value and paying for outcomes. And then finally, extending the analysis and recommendations made by the Productivity Commission. And the Productivity Commission indeed did say within their report that we don't recommend outcomes-based funding, but it was only because they believed that health outcomes weren't being appropriately measured. Okay, so looking at the mental health care funding environment. So what we're proposing really is a move towards value-based payments. And value-based payments really are payments that seek to utilise financial incentives to create a provider behaviour to better align their services to consumer preferences and to consumer needs. And we know that within our system currently, fee-for-service, for example, MBS, it doesn't encourage quality, it encourages over-servicing, it encourages what rewards more volume rather than better quality. We also know that financial incentives can work. The research suggests that it's about 50-50. Now, some people might be a glass half empty and say, well, if 50% of all value-based funding models aren't working, then they're not really working very well at all. But I would suggest that in actual fact, we're going through a learning process. We will continue to learn. And just like we're trying to discover a cure for cancer, for example, not everything is going to work. The structure of value-based payments really depends on how value is defined. Now, that's defined in many different ways. And if we look at the value-based healthcare movement, which was really proposed by Porter and Deesberg, I think in 2006, they were suggesting that value is effectively outcomes divided by costs. So looking at how much outcome can be produced for each dollar that you spend. Other jurisdictions have picked up on that and they have extended that. So for example, if you look in New South Wales value-based healthcare definition also includes patient experience and provider experience. If we just focus on the value-based payment models, we have in some ways been using some of those and we've tested those over the last 20 or 30 years. Pay for performance and capitation, which you're probably aware of, and you've probably seen in some form within a pilot in the last 20 to 30 years. That has been used and it has not been successful mostly within Australia, but there are various reasons for that. And one of those is that when you introduce a new funding model, you've really got to give providers an incentive to change their behaviours. And within a 1 or a 2 year pilot structure, for example, they're really not going to be willing to change their models of care or infrastructure if there is a large associated cost with that and an uncertainty associated with whether that pilot program will continue. We are looking at second generation models now. So 2 of those are called bundle payments and accountable care organisations. They're effectively a contract between multiple providers, multiple provider types within a care pathway that work together under a contract to deliver a number of services for an individual within that care pathway. And they're being explored mostly in the US, but also in Asia and Europe. The US has actually invested $20 billion into the development of bundle payments and accountable care organisations over the next 20 years. And they're hoping to get, if not all, most of their Medicare-funded services under some form of value-based payment model by 2030. Now, the issue with value-based payments models is that it's really just a shift in risk, financial risk from the payer to the provider. And so here is a chart. You may not be able to see the small text at the bottom, but what it shows is different types of payment models. This is in the consultation paper if you want to take a closer look, and their risk-reward profile. So if you look at the bottom left-hand corner, for example, these are models that aren't value-based, and we have things like cost reimbursement, historical block funding, fee-for-service and activity-based funding. They effectively service volume, and there's no real quality component attached to those. We then move into value-based payments, fee-for-service capitation. Capitation can take different forms. But then we look at bundle payments and accountable care organisations, which is in the top right-hand corner. And you can see that there is a trade-off, i.e. the provider risk on the bottom or the horizontal axis increases, but the potential reward, the financial payment for getting it right, increases also. And so that's how the financial incentive is trying to change the behaviours of providers by shifting some financial risk, but also offering a reward. There are, of course, challenges, particularly in the mental health care system. And first and foremost is understanding and sharing financial risk between providers and payers. So a lot of providers won't really understand, for example, what does it mean to move to a value-based payment, whether they will be able to achieve the targets, and what does that mean for their financial risk, and how do they manage that financial risk. There is evidence to suggest that providers may not be willing to participate in a new funding model because if they don't feel as though they can manage that risk, then they are unlikely to participate. There is some research coming out in the US that suggests that if you are to introduce a funding model, then it should be made mandatory because there are some benefits associated with that in terms of the sample of providers that you allocate that model to. Measuring costs across treatment pathways is difficult, and not many providers are doing that. Many providers use fees, for example, to proxy for their costs. They don't understand exactly how much it costs to deliver a care pathway. Funding costs associated with developing new care pathways will need to be covered. Collecting and sharing data on mental health outcomes and costs will have to be improved. There needs to be some risk adjusting to prices to account for heterogeneous populations. So, for example, one provider shouldn't receive the same amount of price, the same price as another provider if that second provider has a more severe patient cohort. And then finally, attributing health outcomes to mental health treatment that separates all those other factors that can impact health outcomes. So, for example, socioeconomic status, family lifestyle, work environment. And of course, any new value-based payment model must consider the interrelationship between mental health, physical health, and non-health factors. And that means that any funding model, if you are to deliver on a care pathway, needs to be able to fund those different types of service that impacts these three types of characteristics that impact on mental health outcomes. So hopefully you can see some of that, maybe not. I'm just going to run through it. So this is the model this is the structure that we are proposing for governing a value-based payment model in mental health care. And what we're proposing is that the government, through healthcare system reform, introduce an independent value-based payment authority. Now that payment authority shouldn't be specific to mental health. It should be general in that the value-based payment authority should be able to develop value-based payment models that deliver that promote integrated care pathways across several types of services, mental health care services, other physical healthcare services, but also other services that impact mental health outcomes. So, for example, employment services. That independent value-based payment authority should be informed obviously by patients and carers with lived experience, providers, PHNs, LHNs and other stakeholders, so presenting a need for the funding a specific type of service. But at the other side, it should also be supported by state and territory governments, federal governments, enabling independent government agencies, so for example the Australian Digital Health Agency and private insurers. We're proposing that the Independent Value-Based Payment Authority creates the model, but then it's devolved to state and territory governments who manage the implementation. Now this could either go through three ways, a PHN or an LHN, a PHN and an LHN getting together, or what the Productivity Commission thought of was regional commissioning agencies, which is effectively a combination of PHNs and LHNs, but they operate as an independent agency with an independent board. We're proposing that this implementation of funding models should obviously be evaluated, and there should be a learning process. Now, this whole thing needs to come with a 10-year vision. We need to give providers and consumers and government an understanding of where we're going, and there needs to be an iterative process of learning. So there needs to be a strong learning evaluation culture that can fit into the next version of model if the first or second version didn't work. Now, the second component is embedding value into mental health care investment. So we know that a lot of the decisions that are made within mental health care are not based on evidence on effectiveness or cost effectiveness. And in some regards, that may be because of necessity, i.e. a service needs to be funded because of an acute need. But we do need, as the Productivity Commission, and I'm sure all of you agree, a better way to think about our investment approach to mental health care. Research outcomes are also not being used effectively by policymakers, and I'm sure as a researcher, particularly when you're thinking about policy or programs, understanding that something can work but it's not being used by policymakers can be very frustrating. But it's also a waste of resources and effort in terms of trying to evaluate and implement better models of care. So within our consultation paper, we're recommending a unified national approach to deciding on alternative investments in mental health care services. There's three components to that. It has to be pragmatic, efficient and risk-based. And when we say risk-based, we don't want something to go through a formal evaluation process, for example, if it's a $1 or $2 million investment. We're talking about larger investments, 10, 20, 50, $100 million, that needs to go through this formal approach. We're suggesting that a formal evaluation process be used, and there should be post-market surveillance to monitor outcomes and the cost effectiveness of those investment programs. Now you might think, well, that's pretty crazy, Henry, having a national approach for investment. How are you going to get the states on board with that? Well, we're not suggesting that that approach tells the states what to do. We are suggesting that there is a recommendation to either invest or disinvest, but that recommendation be transparent. So a minister then still gets to decide which way they want to go, but at least we are as a community aware of the information that they're receiving to make that decision. This is also something that is already being used within the within the healthcare system, but also other areas. So the federal government has the Office of Impact Analysis. It requires a systematic approach to a government investment decision when they're looking at changing regulation. That office is run by the Department of Prime Minister and Cabinet. Similarly, at the federal level, Pharmaceutical Benefits Advisory Committee advises the Minister on pharmaceuticals to list on the PBS, and the Medical Services Advisory Committee advises the Minister on what medical services to list on the MBS. And even at the state level, we have a systematic approach to government investment decisions, which is the New South Wales Gateway Policy, and which is run by the New South Wales Treasury on capital and recurrent New South Wales government expenditure. Now, there's obviously several principles that we need to fill if we're thinking about this, and I've just listed those here. I'm not going to go into them because I'm running out of time, but you can look at the paper and And one of the consultation questions within that paper actually is what other principles should we be thinking about when we're thinking about an investment evaluation process. Now this one you probably definitely can't see. I'm sorry because I didn't realise how big the screens were going to be, but this is the framework that we're proposing for a systematic approach to investment. There is a sponsor who wants an investment, which is at the top, who wants an investment evaluated. There should be a single point of entry for that sponsor to say, hey, I would like my investment evaluated and the government to consider investing in my service. Alternatively, the sponsor may be a government agency or a department. We then propose it goes through an initial evaluation. If that evaluation suggests there should be a full economic evaluation, it then goes to what we're calling the Mental Health Advisory Committee. And that Mental Health Advisory Committee is informed by 3 subcommittees, a lived experience and community subcommittee, a clinical subcommittee and an economics subcommittee. And this is in some ways reflecting the way that decisions are made through the PBAC process. As I said, the Mental Health Advisory Committee makes a recommendation to the Minister. The Minister is not beholden to that, but the process is transparent. And then the decision is made. If the decision is made and there is good evidence, then we may be able to implement that with a monitoring program. But we're also suggesting that if their evidence isn't so great, but there is, the Mental Health Advisory Committee suggests that benefits could be large, we are saying that there should be an opportunity for that investment to go ahead on a temporary basis with an established evaluation plan to assess whether those benefits are achieved. And that's really getting at some of the issues that we have in the mental health care system whereby there may be good programs, but evidence is somewhat weak. Here's just an overview of the proposed process for the post-market surveillance. I've just mentioned that. I'm not going to go through that. So that's the end of my discussion. I just wanted to talk to you about the consultation process. It's being held between August and September. We're undertaking interviews with all state, territory, federal government departments and mental health commissioners. We're also undertaking 3 relatively large workshops, so 40 people each in September with stakeholders. If you're interested in being part of that workshop, please go to our website. There is a registration form and give us your preference as to which workshop you want to belong to. There's also another seminar that will be held. It'll be a more detailed seminar on the consultation paper. That paper is about 80 pages, so there's a lot of information that I haven't covered off here. And there's also an opportunity to provide a written submission to the questions within our consultation paper as well. So I'll hand it over to Gregor.